about where we're at broadly is that people are in circulation more, even on a Friday, which means our society, at least, is coming back here in Chicago in that way. I don't know, I'm not going to comment on society outside the state of Illinois, but at least comment on that. The only problem with it is I did not adjust my travel schedule to meet the demands of our transportation, as it were. So with that, will the secretary please call the roll?
Director Harrington?
Present.
Director Robinson?
Present.
Chair Ryder?
Here. Ryder is here.
And for the record, those directors also present. Director Lowry?
Present.
And remotely connected is Director Green.
All right,
Present.
great.
Thank you. You have a quorum.
All right. So we don't have anyone on the committee who's participating remotely. We don't have anybody on the committee all of our committee members are present.
That is correct.
Okay. All right. The next regular meeting of the Finance Committee is scheduled for Friday, December 13th at 10 a.m. Debbie, is there any public testimony?
We did not receive any registrations nor any written testimony.
Okay, great. Let's move on. So we have the agenda set out. Normally we would go to items under the chief. Oh, first I skip something. The October 17, 2024 Finance Committee meeting minutes. These were approved by the board at the October meeting, but are being presented for the committee's review and discussion if necessary. Chair inquired, are there any corrections that need to be made to the minutes? Yeah. I'm going to get it right. Any corrections? Any corrections? Hearing none. Is there a motion to accept the minutes?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none. All those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. Now, what I was going to say is normally we go to contracts and procurements under the Chief Procurement Officer. But before we do that, I want to take some items out of order. And because we are looking at extensions of two agency contracts that would go until the spring as we look at putting together a new RFP, I would have a lot of questions surrounding the agency contracts, which I think some of our other directors, as we normally do when agency contracts come up. So I think that as some of you recall, or most of you, if not all of you recall, is the Finance Committee is going to start receiving a monthly report on agency usage and our efforts to bring down the number of agency positions that we utilize to get more in line with where we believe we need to be, reduce it, and use agency. What it was intended to do is to fill gaps for things that are not expected, like FMLA and other things, and not become reliant on agency as it has creeped up and in some places taken over some of our operations. So so we're going to have the second report. The first one was at the board last month. This is going to be, like I said, a regular part of our meeting. And then we also have a resolution on agency that we're going to be considering. So before we dive into the extension of those contracts, along with our other contracts we have to consider, I want to get out on the floor the issue, have discussion, make sure that we have alignment on where we're going and the the progress that we have made and continue to make. And I believe that there's also some updates since we last met on the conversion of agency positions to full-time CCH in-house, regular employee, normal stuff, paradigm shifting. You can write that down. That's me just freewheeling it today. So I'm going to hand it over to our Chief Executive Officer, who is going to lead the discussion. And as we get into it, directors can ask questions, but let's get some of the information rolling before we jump into it all. All right, let's jump into the questions.
All right. Thank you, Chair Ryder. Good morning, directors. So we are going to pass this over to Craig and Carrie, and I also, as they're coming up, want to take a minute to introduce Wynn Buren, our new Chief of HR. Welcome, and we'll do that again at HR, which is later this morning.
Good morning. Craig Williams, Chief Administrative Officer.
Good morning, Carrie Primick-Folk, Associate Chief Human Resource Officer. Okay, we're going to start off just with giving some of the same information that if you're here later for the HR committee, you would be hearing then as well, which is our current state of hiring and separation. So the numbers across the top row tell where we are with having extended offers, what's been accepted. We've had 725 external new hires, so people coming from outside the organization and not just moving around and promoting or transferring laterally within. Year to date, we've had, or not year to date, sorry, as of the end of October, we had 445 separations, which cumulatively with our hiring gives us a net new hires of 280. And there's that small blue bubble next to the 280 that tells you where we were at the same time last year. So we're keeping pace and still slightly ahead of where we were last year with our hiring and separation ratio. The bottom just graphically shows that same information year over year from 2019 through end of October this year. All of these are year to date for the same time frame, so we can compare year over year, and it shows you where we were with hiring, which is the bar, and the separations, which is the line graph.
Yeah, it'd be helpful to know the total number of employees relative to the hiring numbers we see. I mean, how many employees do we have?
I don't know, remember the exact number, but we're somewhere around 5,700 employees.
Thank you.
Next slide.
Next slide.
I'm sorry, can you hold up on that slide? Sure. I'd like to ask, if we look on your bottom portion of your slide, I noticed in between 23 and 24, there's approximately 77 difference. Why do we see that decrease when we should be increasing?
I'm sorry, I missed the last part because of the feedback.
On your FYTD 2023, it says 1303.
Yes.
And on FYTD 2024, it says 1060.
Yeah.
If we look at the 522 and the 445, that's a difference of 77. So what I'm noticing is that we actually have decreased in our ability to hire people from last year this time. My question is why?
I think we should clarify this. That's a fiscal year to date probably on a date that doesn't encompass all 12 months.
Correct. It's not.
So that's not apples to apples there.
Oh, I thought she said.
No. Those are. It's
The-
year to date, year over year. So we picked October 31st and we pulled the numbers.
Okay, all right,
Yeah.
gotcha,
Yeah.
gotcha.
So my question still stands.
So we've had more challenges hiring through the last 3 quarters of this year. So our hiring has slowed compared to last year. As you can see, the 1,300 and 1,000 compared last year and this year. We brought fewer people in total, but our retention efforts, which is where some of our energies were also diverted, have been paying off, which is why our net new is still higher. But our acceptance rate has gone down a little bit, as we've been talking about over the last couple of months as well during the HR committee. So last year we had a 70 to 72% acceptance rate for our offers being accepted. This year we are at 60. We're currently at 64, but we've been hovering around 65 for the entire year for our acceptance rate. So our acceptances haven't been going as they were last year. And then in part, it is due to some of the salary challenges. So we've been we have been conducting multiple market analyses over many positions, especially the ones where they're not accepting those offers as regularly as they were even just last year, and so that we can do market adjustments and begin the process to increase those salaries for those individuals at the offer stage.
So the analysis says that it's a function of salary?
In some departments,
in
we have
some-
found a few departments that we have some opportunity to come up to market. We're a little behind, so we're making those adjustments now.
Correct.
Which if I'm, correct me if I'm wrong, when we had our collective bargaining agreements finalized they were negotiated a year or so ago, right?
No,
Or no, 2 years ago.
4 years
4 years
ago.
ago? Is it that long?
We signed them in 2021 and 2022, but they were the data we were using was 2019, 2020 data.
Okay.
Yeah.
When was it that we actually were able to implement the SEIU contract? Because a lot of those positions, that came later than when we actually got to part of the agreement, right? So the salary lines on those didn't go into effect until when?
Their contract was signed in 2022.
Okay.
But it was retroactive, so obviously they received payment going back to when the others had been signed as well. But
Okay.
in the end, yeah, 2022 is when those became official.
And so I think you were starting to say this, is that the salary catch-up that we were looking to do, because there were places where we wanted to put more salary on along with the union to attract people, was based on salaries that were, a salary analysis that was probably not caught up enough because of the pandemic and the rise of wages in other institutions. So now we still have some catch-up to do.
Absolutely, that's correct.
Okay. Carrie, can you tell me, where are the areas that we find the most challenges to, on a salary basis to fill positions?
The laboratory, radiology, respiratory, many of our physician specialty areas, and previously nursing was included in that, but that we course corrected over the last year, which is where a lot of our hiring increase came from last year, because we did course correct with that group, and now we're pivoting to course correct with these other groups that we've seen that lag not get corrected for, because we had the 3.5% salary increases that were implemented countywide last year, and that we had hoped that was going to help us fill that gap a little bit better, and it didn't do it sufficiently in a lot of those areas, which is where our new market analyses are looking to target.
Okay. And we've engaged with BHR and SEIU because I'm guessing a lot of those positions are with the Doctors Council and with Local 73, the
They are.
SEIU locals. So we're engaged with them on picking those salaries up.
We are.
Okay. All right.
Point of clarification, for this slide, these numbers, do these numbers represent FTEs? Is that it?
Yes.
Okay.
Yes. Yeah.
Yeah, I want to possibly offer up some context. During COVID, there was this thing called the Great Resignation, and I think that's behind us, but are we seeing fewer people actually looking for work now because people are more stable? But during COVID, there was mass resignations. People were changing jobs very rapidly. And that might be something that's answered later, but could you speak to that?
So I don't believe that we're seeing fewer people looking for jobs. I think we're seeing fewer people in the healthcare industries where we need to fill roles that are available to us, because that's a nationwide problem that all healthcare organizations are facing as well. So the qualified applicant pool for what we're looking for is smaller than we had hoped. Yeah.
I think as we get into the deck too, it'll provide a little bit more context around where we're using the agency and why, and the drivers behind that, so.
Okay. Continue that.
Next slide, Denny. So this is a view of our current state of agency use, and it'll be a slide that these next two slides will be some reporting that we'll provide here. On the left is just our overall agency FTEs, which is inclusive of nursing and all agency use across the organization. And you can see from September 24 into October 24, we did have, almost a little over 150 reduction in agency usage, across the month. And we're really focused on, really trying to, one, normalize what we need for staff, as well as get out excess staff that we don't need. We've been working very closely in collaboration with our labor partners to create a process to convert our agency staff to employees. Carrie and her team are working through that with the unions, and I would say that would start in earnest in December. And so, you know, going into January, we expect to see continued reduction on this. The next half of the slide really, I think, highlights some of the
Craig,
issues.
can we just pause there for a second and
Absolutely.
talk about that a little bit?
Yeah.
So, how many employees could that potentially, how many agency workers could that potentially impact to convert to full-time?
I want to say off the top of my head, it's like 894 in these kind of categories of current agency staff that we have. Now, I will say, we've embarked on a 10% reduction of that agency staff. So, a 10% of reduction of where we are operating agency where we don't have direct PIDs. But at agency, we're cutting that by 10%. And that's kind of inherent on what we're going to be asking for in the contracts as we move forward. But I think, you know, explained on that staff. So I think there is a real opportunity there. And it's really, a lot of it's focused in those SEIU jobs that are more of the less skilled, high demand positions like building service workers, transport.
I would argue that they're all skilled.
I didn't say not skilled, I just said less skilled. So on the slide on the right, or the section on the right, I think it really gives you a good overview of what our challenge has been.
So just, sorry,
That's
I just want to make sure I draw this out a little bit more. So there's two things that are happening at the same time. One is a reduction in use of agency that we're applying 10%.
Yep.
At the same time, converting people who are current agency, giving them the opportunity to become full-time employees, which they have to elect to do, but we're also going to be reducing agency staff. So that should, on the agency number, that could have a dramatic effect on agency, specifically within those SEIU positions.
That is the opportunity. Converting agency staff that have been doing a tremendous job for us just aren't bad as CCH employees, and getting them onto our paper and being a closer part of our family.
What do the details of our contracts look like with our agency providers? Are there any barriers or we have things built in that would that makes it easier for us to convert them?
So we've analyzed all the agency contracts. I think the biggest barrier we have is with a company called EBM, which does a lot of our building service workers. And there's a 6-month pause period before we can recruit them. Many of the staff that are coming with us are already over that threshold, so we think there's an opportunity to onboard them. But that was probably the biggest barrier when we looked at the contracts.
Okay, but so there's a way to strategically do this where we can maximize on both ends.
Yes.
Using the reduction with the people who are over the 6-month threshold to get some really significant movement.
And we know, I think both anecdotally and factually, that many of these folks want to come on to be employed at CCH. In fact, we've had hiring fairs for building service workers where EBM staff has come in to try to get a job, and we haven't been able to hire them because our old contract with them had a no hire, and we got that down to 6 months in the latest revision of that contract.
How will we be doing specific outreach to those employees or to those workers for that? Is it just like they have to show up at a hiring fair? Are we going to be doing direct recruitment?
We're going to be doing direct recruitment and direct outreach to those individuals who were employed with us when our settlement agreements were signed.
Okay.
And I'm advocating with my colleague to the left to have operations involved in that, because many of our managers already have relationships with these folks, and we think that would be a good way to engage them.
If there's an opportunity where you guys are doing a meeting with a number of these folks, like, I don't know if you would do like a orientation meeting or a recruitment meeting. I'd be happy to attend, because I think I can speak to this as one of the board members who over the contracts. I also know a little bit about full-time employment and the benefits of that with a public sector institution. So
Great.
yeah.
My question is, if you're confident that they're coming on, what is the winning proposition that would beckon them to come on to staff versus remaining with the agency where they can make more money from a raw salary standpoint?
So in areas like building service workers, food service workers, transporters, we don't believe that they're getting a significant increase over what we would pay them. It's pretty market rate. In fact, it's not a huge cost multiplier for us when we use agency in those areas. Hasn't been our strategy. The issue is different there, but we think we're very competitive there. Lab, Kerry already talked to that, is that we need to increase salaries there, so that will be a little bit of a steeper climb for us.
I think Director Robinson, the wild card there really appears to be benefits and the need for them, right? That's the delta. So if they have a significant other spouse where they're getting the benefits and they're doing this as a 1099, they can take the extra funds and not need the benefits, right? So that's going to be, I think, the piece that we'll have to tease out. We'll have to find the folks who are actually going to think that the benefits add is a good thing.
Makes sense.
Also,
You're right.
Makes sense. The reason why I asked the question, because when we look over on the nursing side, that did not add up the way we would have hoped it would have. So
Correct.
I was trying to understand the difference here, given
I
that
do think it's a different economic proposition.
it sounds like it
Yeah.
from what you said. So thank you.
Especially on the building service worker end, because EBM is a union contractor that pays, they have their rate is what prevails, and I believe it's similar to what we have here, but the difference is the benefits and the job security I'm not saying one's better than the other, but I think that there is more stability in working directly for the institution. I think that an EBM employee could end up getting shifted out of this work location to a different work location, and the person who's the principal officer of the union that represents them on the private sector side always tells me that she's a strong believer. She'd rather see public employees in public institutions. They're not looking to represent the building service workers here at the hospital. So there's a value. I think that it's safe to say that on the labor side, there's a uniform position around wanting to support public sector employment.
I think that becomes an even bigger consideration for the agency employees as we consider the 10% reduction, and potentially even, we're still contemplating this, but, are we going to put in place some type of time limit for a specific individual to be in an agency role where, beyond 6, 9, 12 months, that person needs to decide to either apply or move on. So it creates some pressure there to not just remain agency forever.
And just to pull the curtain back a little bit, because I know Craig, Eric, and I have talked about this quite a bit. There's always a preference from the top that we're sort of an outlier on how much we use agency in these roles versus like nursing. I'm not saying that we're at the appropriate level in other roles, but we're probably way outside what we consider the appropriate scope on building service workers and these tech positions.
Yeah, I think, a lot of that has been driven by, right, we're in the neighborhood all in of about 24% vacancy rate across the system, right, where others are lower than that, so that drives a bit of it. And then, FMLA utilization has been something, as we've unpacked this, that is also leading to additional, need, so.
And scaling up new programs that we backfilled quickly, and then just people got used to, I think talking about the and I'm sure you guys are gonna talk about this, the decentralization of our agency hiring and how you guys are reining that in, I think is also an important thing that we need to cover,
And
so.
getting a handle on the use, yep.
Back to you guys.
Sure, sure. So I do think the slide on the right, I think, is a really key illustration of the drivers of some of these positions. So they show, you know, by number of people working here, the number of filled positions, and then the number of agency staff on. And you can see, and then the other key point there is that small little blue dot on each bar, and that what that shows is our actual budgeted positions in FY24. And so you can see for building service workers and EVS, for our food service workers, which is the small bar in the middle, for med techs, not med techs, but transporters, we have less, we're operating at more budgeted positions, more positions than we're currently budgeted for. And so when we have an open food service worker or building service worker or transporter position, we're actually pretty successful in filling those positions in a pretty rapid way. The problem is when you look at the growth we've had as a health system, and many of these services, so labs, transport, cleaning of rooms, are driven by patient days. And if you look at Stroger, we're probably about 20% more patient days than we were 3 years ago. And at Provident, we're also, probably about 50% more in patient days. And so that just drives more heads in the bed, more turnover of cleaning those rooms, more trips back and forth to the lab and radiology and to discharge them, and more lab tests. And so when I say we benchmark, what we do is we benchmark at the unit service level. So we actually look at the volumes of services that these functions need to provide. For these key areas, it's really based on patient days. And so we benchmark against patient days at a unit of service to make sure that we fall within the 25th to 35th percentile in terms of utilization for those services. And that's why we've increased the numbers, because we haven't gotten additional PIDs in the budget. So in order to grow new programs and to actually have nursing that would be able to support the patient care volume that we haven't been able to give new positions to some of these, I would say, non-sexy areas, right? Which is sort of what we're here. So
I think that's a better description. Still.
Non-sexy?
Yeah,
Okay.
just stick with that.
I'm working on it. I'm traveling.
Language is important.
So before I move to the next slide, any questions on that?
Yeah, we've had discussions with, correct me if I'm wrong, we've had discussions with downtown about the PIDs, because they wanted to see improvements in our hiring before they gave us more, so we could, ratchet down, be able to hire in those areas. I think, we know here that we've had to do a lot of moving around of positions to hire into places that we've either introduced new programs or where we need to get some more flexibility to hire. Correct. I mean, we have that one area I think we talked about where we have all the positions filled and then have agency on top of that. So we're moving those PIDs,
We've been able to shift positions around, so we're no longer upside down in those labor source departments. So.
And without having to cannibalize another area for those positions. Because because people pay attention, so we end up taking positions out of some of the other management roles to do that, so we don't touch vacancies in any of our represented roles. So
We were able to add 225 positions to our budget for 25 across these departments.
And then the rest was working through restructure of, leadership management type roles. So.
But that's a big improvement over what we've been able to do the last couple of years where we've had the handcuffs on. So thank you to downtown for working with us on that. So.
And then we didn't cover the bottom left, right, the agency conversion. So we'll be tracking in that bottom left panel as we move into December and the settlement goes live.
We'll start tracking those in this slide on, starting in January, when we have data to report, yeah.
So if we can move on to the next slide. So this really shows sort of 5 positions. So I'll go to the, food service worker as an example. So in FY '24, we currently have 35, budgeted FTEs. We're filling that with 27, people, and so we have 8 vacancies. So our current vacancy rate is 23% in food service. We currently have 25 agency FTEs. So if you add the 27 and the 25, if my math is right, that's 52 people versus 35 budgeted positions. We actually, food service is an area, when you look at our amount of meals we serve on a daily basis, we're actually a little bit under the benchmark, and so we're actually able to add 56 positions to our food service department in the FY '25 budget. And that's where, if you add up the last column to the right, that equals 224 positions, I believe, which is what we were able to add back across the departments. And this is where we really think, for food service workers, building service worker, transporters, clerk 5s, we think there's a really economic, currently, based on current salaries, we can really move those folks over. We talked about medical technologists, which is in our lab, which we need to do a little work on salary. I think same a little bit with farm techs. Farm techs is just a national shortage, because if you think about the explosion of Walgreens and CVS and everything else, they've brought in a lot of farm techs, so that's a shortage area. And then medical assistants, we're really bullish on being able to bring those folks over too. When I talk to my team across the ambulatory care network, talking about this agency conversion is a game changer for them. You know, part of what Kerry and her team have been able to negotiate with downtown and the unions, you know, currently we're only able to offer people at the base of the salary grade and not give them credit for experience. Through this process, we're going to actually be able to give them offers based on their experience, and that will be something we're working on in the month of December.
So I've heard that our overall agency rate, overall, that the whole system is what, roughly? I know it's
About 19%, are we still at about 19, Pam? Yeah.
So it's about 19% across the board. But we see how dramatic we are in these areas. And these areas are the ones that specific, let's take the three highest.
Yep.
Food service, building service workers, and transporters. That's where we think this settlement agreement will give us probably the most bump, and that could potentially bring those numbers down dramatically, which would also, I mean, the fact that we're at 19% with these being so high, means that we'll probably see a shift downward, maybe not dramatic in that overall rate, but we're already at 19, and we could probably bump, I don't know what the math works out, but we will probably see some favorable movement on that as well.
Yep. I mean, everywhere else I've been, agency has been called travelers, right? Because what you had is people traveling from state to state to basically get the highest pay that they could in those roles. Those positions aren't travelers. They're people who live in our community and love to work here. So that's why we think we can.
Yeah, the traveler positions are more in what I think you were calling the sexy roles.
Yes, thank you. I'm gonna just talk less.
You're fine, Craig, you're fine. You're actually
Only
really
when
good.
sitting next to HR, right?
Yeah, no,
Yeah, exactly. I think that's it for the presentation. Oh, no, I'm sorry, there's one more on hiring fair.
Right, so this is a slide that we're gonna keep as part of this update for this particular group, since the HR committee doesn't meet monthly. For those efforts that we are using to bring in and draw in and reduce this agency usage by filling those positions that are currently available, plus will be available to us in the 2025 fiscal year. So this slide, which will also be presented later today during the HR committee, shows that over the course, since December 1st, we've had 19 hiring fairs targeting all types of positions. Nursing is in almost every hiring fair we have, but then also many SEIU positions, our technicians, farm techs, our pharmacists, our surgical techs, our sterile processing technicians. We've done EVS and hospital security fairs. they were very successful for us, and now that we are gonna have these additional PIDs, we suspect that whatever remains from the contractor conversion process that we'll be going through in December and probably into January, will then, a hiring fair could help correct very quickly for those types of positions. So
Okay.
we'll keep you guys updated on that information as well.
So, as we conclude this report, I want to first start out with the numbers on those specific positions are unacceptable, right? And, but with that, I want to say that I appreciate the progress that you guys have made in terms of planning and looking at how we got there, which I don't know that we really got into, Eric. Maybe you can do a little bit of that here in a second about the decentralization of our agency usage. I think we're heading in the right direction, and I'm hopeful that we can be headed there dramatically. So when I say that those numbers are unacceptable, that's just that's how I feel, and I think that feeling becomes a fact when we talk as a board, right? And you guys, we've all heard that message. We've been talking about it for a while, but I think more intently over the course of the last year and a half about that. So I really do appreciate everyone working through this first on the nursing end, because we've actually, if I were to say how we've tackled the agency problem, it's actually longer than that. We've been working on this probably for 3-4 years, and we've tackled nursing first. And, you know, I'm not saying that we're declaring victory on anything yet, but I do think that the hiring has improved greatly on the nursing side. Reliance on agency has, you know, with nursing, which is like the travelers that Craig talks about, that's where agency has always, you know, crept in. On these other areas, it shouldn't look like nursing, and in some ways vastly exceeds it. So I thank you guys for the work that you've put in, that you're putting in now, and that, you know, we expect everyone to continue to put into this project. It could, you know, it'll be transformational.
I have a couple of requests.
Sure.
When I look at the different categories here, we've mentioned nursing. I don't see nursing on here, and I don't see physicians. So if we're trying to move the needle, I think we need to have a category for all of them, and then to see how we're going across the board, because we could make, in the food services, transportation, we could clear the board here, but maybe not move the needle on the amount of money that we're actually utilizing here. So I think it's important to put everything in perspective. What we have in front of us gives us a snapshot of this particular category, but the big categories are not here. So that's what we need to see if we're going to actually do something here.
That's fair, and my assumption would be is that this is where all the focus has been. You know, because we've already tackled, you know, we already have made a lot of improvements, which we've, you know, you and I and others have commented, because we've gotten reports on those. But for this report, I think that all the energy was put around these non-medical or medical tech type of positions outside of doctors and nursing, because that's just where all the effort has been. But to Director Robinson's request, if we could layer into the report the nursing and physician positions, just to get a full picture so we don't lose track of that.
So for physicians, though, we don't actually
Right, I was
utilize
just gonna
much
say that, yeah.
agency at all. It's very, very focused and limited usage, and the numbers, it's not for positions we plan to permanently fill, except in one category, which we've already begun that transition. Happy to report on that in the HR committee report, that ex-HR committee. I think tracking it in this mechanism for physicians probably wouldn't pose useful information for all of you, because we're just not using agency with physicians very often at all.
Okay.
Fair enough. The question comes from the standpoint with physicians is that we have vacancies and we're going over to different hospitals to try and get other people or other physicians to come here. And I'm not sure, but my guess is we may be paying a premium if we're going over to another hospital, asking them to help out. So if we're, again, in trying to get the hospital at the right level to handle the the influx of folks that we have, those things still should be considered, which is reasonable not to consider it here, but then it should just be a separate page stating that because it still is a human resources issue that we're looking at.
Yeah,
Yeah,
so I would say that topic should be for the Human Resources Committee, because this
Fair enough.
is gonna be focused on agency. So let's just layer nursing in there so we can get that picture.
Okay.
So, yeah, so nursing actually is the next, so we'll have Bina come up, but, we actually pulled it out of this report because Bina was giving her full bio report, so, yeah, we
yeah,
didn't
we're
want to
doing
do it
the bio
twice, so, yeah, so
report. That's
nursing's
right.
coming up next.
Okay.
I forgot.
Yeah.
So, Sam, we're doing it.
Hey, there it
And
is,
then
there it is.
Done.
as we switch presenters, you'd asked for a little more background. It was in the original report, and I didn't want to keep repeating ourselves, but, the
Then Joe has-
decentralization. Oh,
Joe has a question.
oh, sure, go ahead.
Not a question, just a comment. Based upon the data that's been presented, it shows that we're clearly moving in the right direction. I just want to say, keep up the good work. I mean, I don't want that to get lost in the conversation.
Yeah,
Good,
absolutely.
good job.
Absolutely.
Well, thank you for that, Director Harrington.
That's why I started out with the Stern one and then said, "Look, you guys are listening."
You wanted some background?
Yes, go ahead.
So, when we started to unpack this, we realized that at the department level, that really was kind of where people were able to pick up the phone and bring people in, to engage the agencies, and it presented, a bit of a control opportunity to, understand the full spectrum of what was happening. There wasn't a system level tracking, ability that's been put in place now. There's now a more formalized approval process for anybody who needs agency. We've also paused any new agency coming in, especially for these more troubling roles, the ones that have been more challenging. So just a little bit of that background of kind of where we started and the pieces that have been put into place. Craig talked about benchmarking as well. That hadn't been a tool that we had been using up until maybe, 6 months ago. So that's been a lot of kind of that analysis that's been going on to really understand where we need to get to that would be appropriate for our system.
So when someone wants to bring in the agency,
There's now,
they have to go through who?
it's a system level. I think we're landing on Craig. Is that where we're? Pam, okay, so it's gonna go through finance, yeah.
Oh,
So,
okay.
yeah.
Lady, hold the purse strings, all right.
All right.
No agency for you.
Yeah.
Good morning, all. Bina Peters, the Chief Nursing Executive. This is the quarterly nursing update on VIA, that agency that we are using. So I added few slides to really share how we manage that. Nursing, we manage agency utilization centrally across the system. And also nursing is a little bit complex because not all the nursing positions go through nursing operations. So that's a future opportunity. So I just want to go through some of the highlights and where we are with it and the progress. Next slide. So again, the VIA contract we executed, just to remind the team, maybe 4 years ago, to centralize all the nursing positions within this particular contract. And that helped us significantly to manage. Before, we used to have multiple contracts, and honestly, we lost in between. So this particular contract was renewed through an RFP process last year. So we do have $140 million under this contract. Next slide, please. So just want to share the group that the nursing has a number of other factors that need to be considered to make the staffing projection. We have a Illinois staffing law that required us to staff based on the equity. I know there's a lot of discussion about ratio, but we are an equity-driven state. And also, we must have a staffing committee consist of more than 55% of the frontline nurses, and we have that in place. And that group will create the staffing plan and make the recommendations. And from a nursing leadership perspective, we look at their recommendations. We also benchmark it to make sure that recommendations and what we think is aligned. And I think so glad to share with the group that we've been working so closely with our NNOC and the frontline leaders to align our staffing plan. So we have staffing plan for all the acute care as well as some of the ambulatory areas. We also we have CBA requirements. So we also built that into the staffing plan so we don't violate the CBA as we are, planning the budget as well as the staffing projection. So in general, Stroger and Providence Hospital, we staff according to the volume, flexible staffing, and CERMAC is the fixed staffing model. And ambulatory staffing operate NNOC positions or RN positions are outside of nursing, direct oversight for operation, only the practice. Next slide, please. So in general, as good news is that all the nursing PIDs or agencies are below the PIDs because we monitor that on a weekly basis, so we don't have more agency nurses than the PIDs, and I shared with the projection. If you look at the projection, nursing overall, have 1,720 positions, and we manage it based on the staffing needs. And also our nursing staffing projection also include vacation, sick time, and paid time. So we don't use that for agency onboarding because we don't pay them any benefits. So that's how we manage this below the budgeted PIDs. Next slide, please. So if you look at it, we do have close to 37% RN vacancies if you take across the system. If you look at, we are making progress, but it's not compared to the national benchmark. This is one area we are way above the national benchmark of close to 10% vacancy rate for RNs, but at CCH we are close to 37%, and that's what we are working to really improve. Next slide, please. So if you look at the direct nursing, we can only, so every agency position directly correlating to a vacancy. We can only remove the agency from our operation until we hire someone. So if you look at, we look at the net hire. What is the net hire? Overall, a lot of nurses do internal transfers. However, they can go from unit to A to B, and then we need to hire staff for agency for B. So we look at the net gain. So we were actually a minus net gain, and it is progressing in a positive trend. And the good news is that if you look at the last quarter of this month, we have one more month to go. We had 22 new hires. Net gain, that's what I say, the net gain. So we are improving, but not the rate where we like to see it. So that's why it's very important that we, really, increase the hiring velocity for nursing to really get to the level where we wanted to remove the agency utilization. Next slide, please. So again, this is always, we have to celebrate from our nursing turnover. We are actually one of the top 10 percentile best performers in the country. Nationally, it is 23%, and we are, below 10%. So it's really good, and I think that's really helping us to, maintain at least our the regular staffing model. And we do have quite a bit activities in place to maintain, to do the nursing retention, including a shared governance structure where the frontline nurses have their voice to make decisions on their practice and also help us to improve the practice environment. And I think, we heard that the last nursing employee engagement survey, nursing scored above the national mean. That is the first time, which is huge for us. So I'm really excited about, our frontline leaders, the staff and leaders to really maintain our excellent nursing turnover as well as engagement. Next slide, please.
Dr. Peters, can you go back to the page, go back two slides back there. On your total net gain for the third quarter, it's -1, correct?
Yes.
So we're not keeping pace with at just the standard, much less filling the vacancies. Would that be correct?
That is correct, yeah. We need to expedite the hiring.
So then that becomes a question, at least I think, it becomes a question of the hiring front. We're still not quite hitting the metric that we need in order to actually gain. So who is that a question for?
I think that's why it's a strong partnership with HR, right? Because nursing, we have a process in place, which is we put the request to hire timely. Because my expectation, my leaders is it has to go out in 2 to 3 weeks, which we do that. But I think we really need to look at all the steps it takes to hire someone, a nurse here. So, and I'm hoping that's going to be an opportunity. We need to shrink that time because I can only replace a nurse when someone really takes that seat, right? Like an example, we may have offer, but it might take another 60 days. So I do have a slide regarding this. It's really looking at the whole steps and the process of how we hire people here.
Okay, and I guess that can be something that we can delve into in the human resources.
I really think that was the right place.
Thank you.
we're actually going to have some metrics to update in terms of timing. There's been some process improvement work that's being done in partnership with HR around, specific steps. So there'll be some metrics that we'll be able to share.
Next one, please. This slide, I mean, if you look at it, I pulled my hair, why are we not able to, decline our agency? So what we do in nursing, the day a person separates from the position to where we put the request to hire, right? And when that person, someone getting replaced that position, it is more than 600 days. I think that's what, when I say that we have to look at the process to see, and what are we doing? Because other places, average hiring time in the industry benchmark is 86 days. That is the separation to someone take that seat. So again, it's only, we were able to analyze the 230 positions because that's kind of what it is. So I think, again, this data tell us we have to drill down and understand the why and cut down the extra steps that we needed to, because it's almost getting 2 years, right? If you look at the numbers for RNs, and non-RNs is 722 days. So again, this is a huge opportunity.
So I get this as an HR question, but in part, would this be due to our application to the, or of the hiring plan? Is that maybe the issue?
I would say a combination of all, right? Because we have, I think, I don't want to speak for HR here, but I think there is a process called lateral transfer, that takes some time. We brainstorm something, but I think it's like, we need to be operational leaders. Nursing is like, when can I get someone to replace, right? So there's a combination where I'm hoping to collaborate and understand the gap.
Carrie?
Processes do have multiple steps. Most of them are actually CBA related, and then once we get through the CBA related processes, we move on to our normal external hiring process through our normal HR policies.
We've modified the CBA policies, though, over time through memorandums of understanding with NNU, haven't we?
Yes, in multiple ways, including adding that extra lateral transfer step that is now included in the process.
But I'm looking at almost 2 years. We don't have a snowball's chance to actually fix this problem if this is it. No organization can function when they have 2 years to fill a position. This is insane. This is absolutely insane. We'll never solve the problem. We'll never solve it.
Well,
2 years?
Hang on. I think that you can, because you have vacancies there. We have more vacancies than we have. How many nursing vacancies do we have right now?
Do you know, Vina, the number exact?
540 something
Okay.
based
Okay.
on the budget we submitted.
So if you have 500 vacancies, you have enough pipeline there to start bringing people in. Do you catch up? No. Do some of the vacancies that we have as part of the turnover factor that we expect to have, I think specifically in nursing, because nursing, we've held probably the line on vacancies more than any other position. What we need, so you can plan to backfill. I mean, that's part of what you can do, right? You can plan to backfill. We can catch up. If we were ever to fill all 500 vacancies, then we probably would need to increase the amount of vacancies to have turnover factor. There's always going to be a process. We can start now, or no, we have started, and we've made positive, the fact that we've made improvements show that we can do it, because we're beating attrition right now, and we're actually we're closing the gap on the amount of nurses that are nurse vacancies. Because let's say, what was the nurse vacancy rate 3 years ago? How many vacancies?
It's on that slide, 30, 40.
It was, our vacancy rate was closer to 35%. I don't remember which year it was, but yeah, it was very high.
And we're at what now?
We are 30.
Oh, no, we were at 40.
Yeah, it's come down.
Yeah, it has
came
come down. We were in the forties we're in the 40s at one point.
So now we've
37.
we've now reduced it down, gone from the forties to the thirties, right?
Mhm.
Wait, but I
Have
think
to
I
keep
heard
it-
37, Bob. So if you're saying 37%, now we're down to 35%, and that's 3 years later.
No,
No.
Carrie's, no.
At
Carrie
one
said
point in
40.
time, we were at 40s, and
We're
now
at
we're
the
down to
40s.
37.
We're down to 37 now. 37 is the number now.
Okay, so now my question would be, when were you at the 40? So I need a date, I need a year, because if what he's saying is true, because the math doesn't add up here. It doesn't add up to be able to do it if we're taking 2 years, approximately 2 years for each position. The math doesn't add up. We will all be gone.
Yeah, I have a different kind of question that might provide some context. Are we unique? Is this something that's only happening here, or is this something, a trend you see nationwide?
Look
in
on the
terms
purple
of-
bar. The purple bar gives you the answer to the question. National RN hiring time is 86 days. Ours is 607. That's why I'm ringing the bell.
So nationally, there is a nursing shortage. There are very few states that are
We're all
not,
aware of that.
right, no, I understand. So there is a national nursing shortage that we are competing with. We were coming from a greater deficit than we have now, and I believe what Bob was trying to get us to was that we've been making system improvements, we've been making process and policy improvements as well to decrease that number, and it won't happen overnight because we were coming from such a deficit, but we are definitely making those strides. So last year, we created a new accelerated hiring process.
That's
We saw
fantastic.
some really good traction on that, and so we're implementing it now as a permanent part of our processes, intending to keep that going and to continue to decrease. What we don't have is a lot of historical data on what Bina is presenting on this particular slide because it was never captured previously, at least from the HR perspective and the way Bina has captured it right here. So I can't actually compare apples to apples based on these numbers. Historically, moving forward, obviously, we
Yeah.
can.
So with this slide, when you look at national hiring time is 86 days, it's a completely different process potentially, and it's not tracking the same process. What you wanna benchmark against is an institution that is similar to CCHHS. Like, you wanna look at Parkland in Texas, you wanna look at University of Illinois Hospital down the street. You probably wanna look at, not public sector, but has similar, like, represented by the same unions essentially, probably, University of Chicago Medical Center. And they're all, what you're benchmarking against for an institution like this is a lot different than, say, benchmarking against Franciscan, right? Where a couple of our folks used to be, where they don't have any representation. They also contract and expand their positions at will, so they can make the numbers look different than what they actually are. So we have a higher standard on how we do our hiring. We also have a higher standard on how we do our metrics and how we measure, and we have a longer process. Now, I don't disagree that if that number is such an outlier, and I want to know if it takes us 1.8 years to hire someone in nursing, I'd want to know what triggers the event, and is it critical need at that point? Is it a retirement? Is it someone quitting? Or is it when we post the job, when we fill the job? And are the other institutions tracking it the same way that we're tracking it?
Correct. These are not from time of posting a vacancy to the public, and that is not what these numbers are representing.
So I can speak for this number.
What's that number?
For us right now, our time to fill for nursing is 107 days,
Okay.
as of the last quarter.
So when we used to benchmark this back in the finance committee 8 years ago, I'm going to say we used the nurse hiring number was the amount of days was somewhere in the 90s. That was
Yeah, that's probably accurate.
that was pre-COVID.
Correct.
that number, I believe, we benchmarked against this number that you see up here now is that 89 days. We're benchmarking this number now against that number, which takes in our internal processes in terms of, and by the way, those internal processes on posting are about, we have a nurse vacancy, and we go through and offer those, we post it internally first to people who are here. So the question is, what is the proper benchmarking? Is it benchmarking, is it including our internal posting system, which a lot of other institutions don't do that. They don't post internally, they put it all out at the same time. So there's no internal posting and then going out to the public. You post internally and externally all at once.
Well, Bob, I think I need to ask a question. If the objective is to reduce the use of agencies, then if we're going to post it internally, it should be posted internally and externally at the same time, because time is our issue here. And then they would be given the preference. So if you say, hey, we're going to post it out there, when the internal people come in, we put them first and give them the opportunity. But if they drag and wait around till later, then they're going to get in with the rest of the folks.
Carrie, that's guided by the CBA.
That costs them too much money.
That's a collective bargaining issue that we have to, and the union has been flexible on this in the past. But my point is, Sam, is that we have to look at what we're actually comparing against, and the fact that we're actually, when you go, it's like any time you're playing with percentages, right? Let's say if you go moving from 45% to 37% is more dramatic than moving from 20% to 10%. So I would not discount the fact that we've had a trend moving in a positive direction with our staff working with the union, because the next jump will be more dramatic than the previous jump that we made.
So if I can add, I think this gives kind of an all-in picture, and Bob has kind of said this already, right, of the full process that we're dealing with in terms of the request to hire and the decision to hire and all these additional steps that other systems don't really need to deal with. When we do apples to apples, it's pretty close, but there's all these other pieces in the process that we're dealing with, right?
We're happy to engage with.
What's that?
You know, it's been stated that,
Deal with
Yeah, well, it's extra
everything.
steps we have to take, right? So,
it's been stated that if you can Google the answer, you're not asking the right question. But with that noted, U of I's process is noted to be 4 months.
Correct. And so we're less than that.
So,
for
but
our
again,
nursing.
and this comes back to the performance improvement work and all, well, in terms of apples to apples, right? So 107 days is measuring the same thing, right? So they may not have a request to hire process, the additional steps that we're taking, right?
Bill, that's 4 months when they go to the public to fill a position?
That's what it seems to.
Yeah.
That's what it seems to.
So we're beating U of I right now.
Yep.
Correct.
So this paints a picture of the full process, and that's the piece that we're really trying to work through. Where are the opportunities to really trim those extra steps down? Like, what can we control internally to make it more smooth?
As a Michigan, even though I'm an Illinois patriot, and I have to revisit this after recent developments, but anytime Illinois gets beat specifically by the Navy and maize, I'm usually happy. So.
I'm sorry, Dr. Peters, I think your slide is wonderful, because I think it brings to light where there should be some changes made. And Carrie, I think your responses are appropriate, but the bigger question still lies in, there has to be an adjustment, because, guys, it's simple math.
No, absolutely, and as Dr. Makaitis mentioned earlier, we have been engaging in those process improvements at each phase of the process to make sure that we are trimming that down and becoming more nimble with our processes, so that that pain is not felt at the department level, as she's depicting up here on the slide.
And it was seen inside even the bargaining, you would want the people to be able to get the job faster.
And as going into collective bargaining right now, that is exactly where we are headed with our labor team, because this is our opportunity in successor bargaining in 2025 with all of the unions, particularly NNOC, for us to start to tackle those at the contractual level and make those inroads instead of in the subsequent agreements that get attached to a contract, which may be temporary in nature, to make them more permanent in this collective bargaining.
And you have to appreciate on their side, you know, the unions looking at bringing people in to meet nurse staffing levels while also balancing the folks who already work here and make sure that they're able to, you know, get, the benefit of having a preference for applying for those positions. And internal posting for positions, while it may not, you know, as people's, as you look at private institutions that don't have representation, that function has eroded over time, you know, people who work here, you know, I think appreciate the fact that they get to engage in the process before it goes out to the rest of the world, that is something that, and by the way, is another benefit to working here, coming in, is that when you get here, you don't get passed over for an outside hire. You get the first shot at it.
Right, but my statement is not about passing over anyone, it's just saying you can't have all year to do it.
We're, like I think Carrie said, we're engaging in that process. It's just not an all or nothing proposition, that there's something that needs to be worked through. Joe, it looks like you.
Yeah, I just want to make an observation. I don't think anybody is satisfied with where we are, and we're presenting data to show that we're working toward improving the situation. The other thing is, I don't see people bargaining away rights they already have. You know, if somebody's got a right and they're organized in a union to do something, I don't see them bargaining away those rights. So I accept the fact that we're moving, and we're trying to move in a positive direction. I don't think the numbers for anybody are acceptable, but we're doing the best we can under the circumstances we find ourselves.
I hear your statement, but I think the circumstances can be changed, because without the union losing anything, it's.
Well, I think we're getting into an HR discussion, and the HR committee has time on the books that we're pushing into, and we're squeezing QPS.
I was gonna ask if we could count this as both.
Okay, fair enough.
We still have 45 contracts to
Right,
go through.
so I was gonna ask Bina, if you have like one summary slide just to wrap things up, we do have to.
Deb, can you go to the last, but the good news, right, always, right, we've been working on agency. Year to date, this slide is the summary where we have close to 20% reduction in the overall cost of the agency, because we managed the rate decline significantly. So that's a good news, our financial spending decline. Maybe can you go to the last slide? The last slide is, this is, let me summarize this, that's your slide. So in summary, there's so many processes in place to really manage the nursing agency based on the market cost, based on the benchmark. So we are below the benchmark on all aspects of nursing. So that's summary. So this one is like, again, these are the progress towards what we are doing, and let me turn it back to Charles to talk about his two slides.
And I apologize, because I think you actually have some wonderful slides that I would have loved to have an opportunity to hear you speak on, and I guess I asked too many questions at the beginning.
Well, we had a lot, this is a meaty day, so, Charles, whatever we could do to wind this up so we can get to your other report.
Yeah, sure, very quickly, because I'll bring this home with two quick slides. Charles Jones, Chief Procurement Officer, good morning. So, the slide before that, Debbie. The slide before. Yep. So here, you see, we, going all the way over to the right, we're presenting for this quarter for June and July of 24, 12,000 hours used by minority contractors, 6.5%. I just want to, even though last time we met, we showed you March through May. If you see, even though we're trending down in hours, the usage of MWBE stayed flat. So therefore, since it's linear, I'd just like to point out that this shows that the overall usage of agency has declined since the last quarter. And then last page there.
Sorry, Charles. Is that it?
Just quickly, the last page.
Okay.
And right here, this last page shows you of all the 58 vendors that we're utilizing nationwide with the vendor pool. The upper left here has Cook County and City of Chicago certified vendors, 5 vendors, which is 9% of those are in the pool. These are what we get credit for because they are certified by the county and the city. Other minority agencies is the second slide here, that's to the left, 14 of those, which is roughly 24%. So right now, 32.7% of the vendor pool are MWBEs.
Okay.
So, I think an important question. I heard that percentage. Relative to actual spend, what's the percentage?
The slide before, 6.54%.
I think that's an opportunity for improvement. And I think as we go forward, we always have to ask that question.
So
Thank you.
normally we would have the MBE report today too, MBE, WBE report. We're gonna hold that for the board meeting, just in the interest of time. And, Bill, you probably will, take interest in that. We generally are, working forward on, always see positive improvement on that end. That was also your predecessor on the board. It was one of the places that him and Charles also did a lot of work together. So, all right, thank you. Charles, you stay there. We're going right to contracts. Just so everybody, gets a preview. There are a lot of contracts. We are going to hold the MBE and emergency purchases report for the full board meeting, and also Pam's report on financials, and we're just gonna finish the meeting out with everything that we need to take action on today. And we need to, before we start with contracts and procurements, and since we just finished up on agency, we have the proposed resolution regarding agency usage that has been circulated to all the directors. The only change, there is a floor amendment to it. So I think that we'd have to put the motion on the floor for discussion and then move to amend it. So I am going to ask if anyone would like to move the proposed amended resolution regarding agency usage and the strategies that will be implemented to reduce such use. If there is a motion to adopt the resolution.
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and seconded. Now we're on discussion. There is a amendment as the county board has entertained or is entertaining a resolution. They've updated their resolution to ask for a biannual report on the benchmarks and progress in meeting them to Cook County's Board Health and Hospitals Committee until goals are achieved. So the amendment would be to strike quarterly and replace it with biannual to be consistent with the county board's current proposal on the floor. If something changes there, we can also come back and adjust it here. I would move that as a friendly amendment to the motion. I believe Director Harrington, would you accept that as a friendly amendment to the?
Yes.
Okay. Is there a second to my motion to update the to make this change to the resolution? Okay. Motion's been made and seconded. Any discussion on the amendments? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? Ayes have it. In the interest of time, this resolution was presented at the last board meeting, I would expect that everyone's reviewed the resolution. Are there any other questions on the resolution? This was also why I wanted to lead with the agency discussion, so that everyone was in alignment around where we're at, or at least had the information. Are there any questions on the resolution? Any further questions? Hearing none, I would add that we are going to continue to develop benchmarks. As we saw today, we have some areas that are really super high, way above where our average is, and we are going to, I think we need to see what December and January holds on those items, so we can probably see where we land after this conversion, so we can establish, appropriate benchmarks, which this resolution allows us to do. Without any other questions, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. Thank you all. We're now going to go to items under the Chief Procurement Officer. Our Chief Procurement Officer, again, is Charles Jones.
Yes, Charles Jones. A little housekeeping, 45 items before you today, 44 of them, 44 contracts and 1 expenditure. Of the 44 contracts, 42 require responsive letters from the Office of Contract Compliance. We have 26 back and 16 in process.
All right. First up is Dr. Lamar Hasbrook, our Chief Operating Officer for Department of Health.
Good morning. So we have one, and I'm going to pitch it for my colleague with another one. So just for ease and simplicity. So the first one here is an increase in contract. The vendor is American Vending Sales. Fiscal impact is $65,000. This is through 11/30/26. It is to procure additional vending machines as part of our opioid harm reduction program and naloxone distribution. It is sole source because we want to make sure we're consistent with the machines that we already have purchased in terms of hardware and software.
All right. If you want, before you leave the stage, do you want to then jump to number 6 and we'll come back to 2 through 5?
Thank you. That'd be great. So on behalf of my department as well as the behavioral health, I'd like to present number 6, which is an extended increase contract. The vendor is a subscription with cellular modem. It's called IQ Technology. Fiscal impact $241,000. This is through July 31 of 26. And this software allows us to do real-time tracking of the use and distribution of units of naloxone through the vending machines. All right. And that's it.
Any questions for Lamar on his 2 items?
Okay, thank you.
Hearing none. All right, next up is Aaron Galiner, our Chief Administrative Officer for Health Plan Services.
Good morning, Director.
Aaron, you got 4 items. Let's hit them.
The first item here is for Centauri Health Solutions. This is the final renewal option on a contract for SSI and SSDI application assistance for our county care members. The next item is a extension of a contract with Housing Forward, which will also relate to the next contract I'll speak to. Housing Forward receives federal funding for housing units that they then dedicate to county care members, and then we fund permanent supportive housing supports that wrap around those members in those units. The next item is the new contract for that same program. We've consolidated multiple programs we have with Housing Board into one contract here. These are maximum not to exceed amounts of $2.5 million. The final amounts per year will depend on how much federal funding is awarded and how many units are dedicated to the county care members in a given year. And then my final item, this is a sole source and is related to a state statute that was passed requiring services for breast cancer navigation and screenings with the Illinois Medicaid program. Illinois Medicaid has partnered with Equal Hope and flowed down some of those requirements to the MCOs, including county care. As a result, we're putting in place this program, total fiscal impact of $497,000 over the next 2.5 years.
All right. Any questions for Aaron? Thank you, Aaron. Next up is our Chief Medical Officer and lover of gym shoes, Dr. Claudia Fegan. Claudia, looks like you have 7 through 9, unless Aaron's jumping in on that last one. So, Charles, you look like you want to say something.
So, Chair Wright, I'm Item Secretary. Before Dr. Fegan presents 7, we'd like to, for the record on the floor, we'd like to amend this request. There was an amendment that has been done to take this contract, under my office, that takes this contract to November 30th, 2024. So therefore, today the request is to revise the contract period from 12/1/24 through February 28th, 2025. So instead of 6 months, it's just 3 months. The overall impact is still no physical impact with no increase, and taking the contract to March, same end date, February 28th, 2025.
Yeah, so this is a clinical service contract. Clinical services agreement. We've had an agreement with Rush previously. We're currently in the process of a new clinical services agreement and a academic affiliation agreement with Rush. And they have requested that both come together. And so while we work out the details of that, we're just extending a 3-month extension. And as Charles said, there's no financial impact. We still have funds left on the previous contract. The next contract is for scopes and equipment for OB-GYN. I know it seems that we're always purchasing scopes, but these are for towers and scopes for use in the operating room for obstetrical patients and, gynecological patients in particular. And it's an area that we haven't previously covered. And the last one is a contract for glucose monitoring devices that we provide through our diabetic patients, glucometers so patients can check their sugars at home, as well as the continuous monitoring devices that patients wear. And this is improving our diabetic control. It's a good initiative that's been very successful over the years. I'll be happy to entertain any questions.
All right. Any questions for Claudia? Hearing none. Thank you, Claudia. That takes us to request number 10 and 11, being presented by our Chief Equity and Inclusion Officer, Shannon Andrews.
Good afternoon. The first item up before you is a request to extend and increase the contract with Lindy Gas and Equipment. This vendor provides medical gas, as well as supplying the tank rental for us as well. This extension will take us through December of 2025, not to exceed an additional dollar value of $900,000. And this covers gas supplies for the entirety of the hospital system, including CERMAC and JTDC. The next item before you is a request to extend and increase a contract with Deloitte Consulting. This firm currently provides support to us in the supply chain optimization space. We are currently working on an RFP to seek ongoing support. This contract will serve as a bridge. It will take us through May of 2025 with an increase of $598,095.
All right. Any questions for Shannon? All right. Thank you, Shannon. Now we're going to go to request number 12 through 14. Pam Casera, our Chief Financial Officer.
Good morning.
Curtis
Haley, Chief.
It's Curtis Haley.
Pull the switch on you there.
Yeah.
All right. The first contract in front of you is Great Lakes Medicaid. This is a request to extend and increase this contract for 1 year while we go to an RFP. And Great Lakes Medicaid provides secondary appeal services for Medicaid applications that were denied for our patients. The next one is an extend and increase as well for Health Management Association or Associates. This contract assists us with our cost reporting requirements and we're going to be exercising our second one-year renewal option on this contract. And the final contract is a request to execute a new contract with 3M. This is a multi-year contract. We currently have a one-year contract with them, and this one allows us to get some savings with the multi-year. 3M is our coding software we use for the system, for the computer-assisted coding.
All right. Any questions for Curtis? Hearing none, thank you, Curtis.
Thank you.
We're now going to go to, the next 5 are going to be presented by Angela O'Banion, our Chief Information Officer. Just to go back, Claudia, Shannon's got really good shoe game too. Not Jimmy. I like it.
Good morning. Angela O'Banion, Chief Information Officer. The first item before you is for CDW, which is one of our GPO vendors. This product is a second generation of ambient technology that allows providers to speak into devices to not only record dictation, but to also get clinical diagnosis from artificial intelligence. We have been using this product for a while. Previously, it was purchased under our, Nuance was purchased under our Oracle contract, and now Nuance has moved its services to the Microsoft contract. And this moves the fees for that from one to the other. And we are also expanding our licenses as we continue to move forward with our artificial intelligence. The next item is a product, is for multifunctional devices for scan, print, copy. We are putting this contract out to bid. It's been with Conica for a while. Services and technologies have changed over time since we first entered into this agreement. So we already have the work in process with our supply chain management to put it out to bid. The next item isn't one that's used by technology a lot, but we are actually centralizing it under us. It is for a vendor GRM. It's an extension for this product, this service, which is primarily document management. It includes physical storage as well as digital storage, and this also is another contract that is going out to bid, as it's been a while since these technologies have changed since we began doing business with this vendor.
All right.
The next item I will take for Dr. Nutter, since I'm sitting up here, unless he really wants to do it.
Okay. Well,
okay.
It doesn't matter to me. We got.
Okay. So the next item, as you know, we have a Express Care digital application that is accessible through a mobile app. We are adding to that via our ARPA funding the behavioral health component, such that if someone calls, remotes into the app, which is a video ability to receive care immediately, we have a resource that will be available to us to manage behavioral health items, whether it's some immediate care or a referral or a future appointment.
And why don't we have you do the
I am.
Yeah.
Yeah. Next one's well for Curtis. Atos is a vendor that we've been using for years. It is one that we use for several of our technology implementations and process optimizations. We also use a service that Atos acquired from a company called Breakaway, called Promise Point. Curtis is in the process of putting this out to bid, but it is a service that we need to extend and increase for another year while that RFP process is in place. This is very sophisticated training technology that we use for our providers and others.
questions for Angela on any of those items? Hearing none, thank you, Angela. We're gonna welcome Carrie back to the table to present item number 20.
Good morning, still. All right, Carrie Primick-Bogue, Associate Chief Human Resource Officer. This is our result of an RFP. We've selected Deloitte to be our solution for fulfilling some HR optimization initiatives continuing from the previous emergency contracts over the last couple of years. They're to cover recruiter on demand and recruitment process outsourcing, HRIS, service link and case management portal improvements and enhancements, organizational workforce development and performance management design and development of modules, as well as assisting in our performance management outreach and rollout over the next year, and HR operations, workflows, and process improvement initiatives. It is for an amount not to exceed 9.2 million years over the next 12 months, starting December 1st, ending November 30th, 2025, with 2 one-year extensions added into the contract if needed. Any questions?
Any questions for Carrie? Hearing none, we're going to move on to request number 21, Life Sciences. Dr. Spranka, our Chief Scientific Officer.
He's
Good
not
morning,
with us in the room.
directors.
Debbie, is he online?
Good morning,
Dr.
directors.
Spranka is online.
Good morning, directors. Can
Dr.
you hear me?
Spranka, are you there?
Oh, there we go.
Yes, can you hear me?
We can, if you could speak up a little bit, that would be great.
Okay. Good morning, directors. I'm Mark Spranka, Chief Scientific Officer. This request before you is to continue services being provided by Huron Consulting in our continuing efforts to build out the Life Sciences Department. The request is for 3 years, approximately $4.05 million. And some of the specific things that we're asking Huron to do varies from year to year. The first year, it's mostly completing the ectone transition of grants and staff and continuing our maturation of the internal operating environment to assure that we're responsive, compliant, and scalable. In the out years, it'll be to pivot towards the growth phase of the life sciences department.
Any questions for Dr. Spranka? Hearing none, thank you. Next up, we have a lot of requests brought to you by our Chief Administrative Officer, Craig. Craig, in the interest of keeping the flow going, I don't see Donica in the room. Are you going to be presenting items 40 through 44? So why don't you do your 22 through 38, do 40 through 44, and then we'll come back to patient experience.
Sounds great, thank you. So these first 3 are the 3 agency contracts that we talked about earlier, focused on the positions that we discussed. So I would say all 3, we've looked at our run rate over the last 3 months, and we've applied that 10% reduction I spoke about, but we haven't made any other additional assumptions around onboarding staff. So we don't expect to spend the full amount of these contracts, but we think it's important to be able to thread the needle on the conversion that we ask for these amounts. So the first one is cross-country staffing. It's an extended increased contract for $27,290,000, 6-month contract period ending 5/31/25. And this is for staff within the Department of Radiology, Respiratory Care, Medicine, and Cardiology. Maxim Healthcare is an extended increased contract for $11,616,000, 6-month contract through 5/31/25. And this is for transporters, lab staff, as well as some of our other support positions. The next is Corsair. It's an extended increased contract for $5,475,000, 6-month contract ending 5/31/25. This position is also, we have transporters, some of our support services, supervisors, and lab staff under this contract.
So, Craig, this is a 6-month extension. We're implementing all these different changes, some of which you baked in, but I'm guessing that you're developing an RFP for when these extensions are over, when are you gonna start writing that new RFP, and what, are you gonna be collecting data for that, for how we might adjust considering the changes that we're making?
So certainly collect data and we'll report out on our actual spend. I would actually ask Shannon, to speak a little bit about the RFP, because it's broader than just these three contracts.
Yeah, I can do it. Again, Charles Jones, Chief Procurement Officer. So we've actually, posted the RFP, and it's down and it's gone through the evaluation stage. So, at some point, within the next several months, we'll come back to you before this expire with the new contracts. And, with that too, if we get them to you earlier, we will have an opportunity to, terminate these earlier if necessary.
Yeah, so I guess my question is that we just had a robust discussion. We're extending for 6 months versus going with a full RFP now. My hope is that we're gonna learn something between now and the expiration. Will we be able to adjust to anything on those contracts based on what we learn in, like, say, the next 2 months?
Yes, since we haven't announced yet and we have an opportunity to negotiate with the vendors, we could trend stuff down and tailor it the way we're going.
Okay. I think that's important for us to know if we're approving this extension. Thank you.
I think it's also critical, if we are indeed going to make grounds here, we need to cover some more information, because I'm looking at the number and I'm looking at the time. It's a lot of money, very short amount of time. And it's a big issue that we don't seem to necessarily have a good grip on. So let's see if we can actually have some plans in place to be able to actually reduce the number of a significant amount. We can determine what significance looks like. I'm not putting anything down, but I'm just saying, we've been talking about it for a while, so let's see if we can do it.
I think the only thing that I would challenge in what you said, Sam, is I do think we have a good grip on it. I think that we need to know how successful we're gonna be in the, agency conversion and on the right sizing by the 10% reduction that isn't just in the contract, but we're actually gonna be working with the vendors to implement a 10% reduction, which is reflected here. And I think that with the scope of people we have on agency remember, the agency, we're way above where we want to be. Some agencies necessary. I think we believe that it's probably south of 20% or so, just on every category. If as we work towards that, I'm just pulling that number out because it's a number that's been kicked around a lot. But still, even if you're between 10 to 20%, you're still probably talking millions of dollars, because we have 5,700, is it 5,700 active employees or 5,700 with including vacancies?
So we have over 5,700 active employees. We have approximately, in the 24 years, 7,300 positions, which includes the 5,700 plus the vacancies.
Yeah. So once you load all that in, and you figure that 20% is, 10 to 20% is vacancy, you're still in the millions of dollars. Okay. Even on a short period of time.
So we can see.
Yeah.
Okay.
All right.
Great. Next contract, please. So GE Precision Healthcare, this is an extended increased contract for $4.5 million, 6-month contract extension through 5/31/25. GE provides our biomedical engineering services, and we have an RFP that's in the evaluation phase. So this is just to get us through that RFP process. Anchor Mechanical is an extended increased contract for $2,697,000, 12-month contract, which would end 11/30/25. And they provide monthly maintenance for the refrigeration and ventilation equipment at Stroger. Jones Lang LaSalle is extended increased contract for $1,662,000. We're asking for a 6-month contract period, which would have started 8/5/24 through 2/24/25. They provide our facility management leadership across our buildings and grounds departments, and we're currently in RFP in the decision phase for the next version of that contract. Johnson Controls is an extended increased contract for $1.3 million. So we're asking for a 12-month extension through 11/30/25. They provide testing, maintenance, repair services for our security systems, building automation systems, and our two-way radio systems. We're actually have an RFP that we posted in early 2025 for this contract. Convergent Technologies is an extended increased contract for $300,000, 6-month contract ending 3/31/25. And they provide maintenance support for our fire alarm infrastructure. And we have an RFP in process for these services, so this is just to get us through that RFP process. Hill Fire Protection, also extended increase for $300,000. It is a 6-month contract extension through 3/31/25, similar to the earlier one. There's an RFP in process. They provide our, our fire control testing, as well as our fire extinguisher inspections. The RFP that's in place could potentially replace these or one as multiple contracts, so we'll see as that rolls out. Dayspring is an amended, extended, increased contract for $3,042,000, 12-month contract ending 11/30/25. They provide janitorial and cleaning services across all our ACH and clinics, and we're expanding this to include our new Bronzeville clinic. We'll be opening early '25. Powerhouse Construction, small contract through our capital improvement program for $372,807,000. This is my record contract presenting here. It's a 60-month contract, 1/1/25 through 12/31/29, and this is a construction manager at risk contract. So they're going to manage about 35 capital improvement projects here at Stroger Hospital, mostly focused on infrastructure. So the building's a little over 20 years old, so it's really improving and replacing all the mechanical system, elevator upgrades, but also has a number of clinical program expansions there, as well as demolition of Hectone, Polk, the admin building. So a lot under this contract, and the CMAR allows them to manage all the projects and are at risk for that total dollar amount. CE Pro is an execute contract for $6,543,000, 36-month contract ending 11/30/27, and they provide maintenance around our air quality and ventilation systems across the system. Prism Holistic Care is an execute contract for $3 million. It's a 36-month contract ending 11/30/27 that was chosen through an RFP, and this is for our new maternal health doula program. So they'll be providing bilingual doulas and navigators to support patients receiving prenatal, labor and delivery, and postpartum services at CCH. Olivio Medical Center is an execute contract for $1,650,000, 36-month contract that was chosen through an RFP ending 12/31/27. And they are our current vendor of our patient navigation system services around prenatal and labor care, and they provide bilingual navigators to help new moms and other patients get services across our system. Progress Dental Labs is an execute contract for $447,000. It's a 36-month contract at 11/30/27. They provide dental lab services to our dental and oral health clinics, and it involve surgical implants and prosthodontic services. Equip Systems is an execute contract for $399,000, 36-month contract through 11/30/27. They provide cleaning, disinfection, and refurbishment of many of our our steel equipment across the facility, which tends to get rusted and creates a infection control risk. So they come in and completely modernize that equipment, and that'll be at both facilities. Standard Textile is an execute contract for $150,000. 36-month contract through 11/30/27, and they will be providing window shades as well as other textiles across the system. And then, Debbie, if you could move to Donica's list. Okay, Inari Medical is amended and increased contract for $216,000. Contract, would end 3/26/26, and they provide, aspiration guide catheters, designed for efficient and effective removal of blood clots in our interventional radiology department. Quest Diagnostics is an extended increased contract for $6.6 million, 12-month contract period ending 12/31/25. They're our reference lab, so for labs that we can't perform at Stroger, we send them out to Quest to process those labs. MedSpeed LLC is an extended increased contract for $170,000. We're asking for a 6-month contract extension through 5/31/25. They provide courier services for patient samples and to bring back to the lab. So patients that have samples taken at Providence, Cermak, any of the CCH clinics, this is the courier service that gets that back to the main lab. Rush University Medical Center is an extended increased contract for $149,999. It's an 8-month contract that ends 7/30/25, and they provide a renal pathologist who performs kidney biopsy studies. He also is available upon consultation to our physicians and leads a monthly meeting for the Department of Pathology. And the last one for me is Helena Laboratories. It's an X2 contract for $206,710. It's a 36-month contract ending 12/31/27. And they provide technical assistance, software upgrades, and support for a Nexus instrument within our labs. Any questions? Thank you.
All right. We're now going to go back to request them. Thank you, Craig. Very efficient. Go back to request number 39, patient experience. Lynn Danger, Chief Experience Officer.
Good morning. So this is a request for, to add 3 service lines offered by Prestini to help improve our patient experience and response rate. The duration would be January 1st, 2025 through March 31st, 2026. The total amount is $139,653.75. The 3 service lines are the interactive voice response phone survey. This will be in addition to the mail survey, and research has shown that the dual mode actually has improved response rate. And then the predictive rounding, it's an AI-driven platform utilizing algorithms to identify high-risk patients to prioritize, such as fall risk and patients who need extra attention. And then the last one is the discharge phone calls. This will free up our staff to focus on patient-facing by allowing automated system to call discharge patients. And that's it.
Thanks, Lynn. We're going to now go to request number 45, our last request. Bina. This is under nursing. I'd also like to note that we had a couple directors come in because I don't know if they intended to attend finance, but Mia's here and Jay's here as well. So, yeah. I figure I'm like, I wonder why he's sitting at the table. Oh, because he's like thought he was going to be sitting here at this time, and I surprised everybody. Okay, Bina.
Okay, good morning again. This is, the request is to pay $32,000 to Loyola University. They actually helping us to support the HRSA grant for the APR and fellowship program. So this is something we owe them. And they had some issue with the billing their process plus, our contract. So I think that delayed us to pay them for the past 3 years of their support. Again, it's a HRSA funded grant.
Any questions for Bina? Hearing none. Thank you, Bina. That brings us to the end. Charles, do you have any closing remarks? I would accept the motion to approve item 4A, contracts procurement items containing request number 1 through 45 as amended, subject to completion of review by contract compliance. Is there a motion?
So moved.
Motion is made. Is there a second?
Second.
Motion's made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it.
Thank you.
Satisfied.
We're now going to move to, our last substantive item, receive and file grant award, related items. So Pam, you only get this report.
Right.
Okay. You get to make the other one
That's
next
fine.
week?
That's fine. All right,
Recap
thank you. Pam Casera, Chief Financial Officer. The item before you is very quickly the receive and file grant awards and renewals. We have 4 awards before you today totaling $3.7 million. They're all extensions or renewals, and 3 of the 4 are Dr. Hesbrook, who is still in the room if there are any questions. And also the last one is Dr. Fegan.
Any questions on the grant award related items? Hearing none, all those, is there a motion to receive and file item 6A, the grant award related items?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? Ayes have it. All right. With that, we are deferring, as I mentioned earlier, our MBEWB report, our report of emergency purchases, and our September financials, and anything else that we may have skipped that I haven't mentioned. None of those items require action taken by the committee. They are informational reports. We have exhausted the agenda, and we are now adjourned. Thank you.